what we presented with you. Also, you might want to download the slides of what I'm going to present, and they can be downloaded here using this QR code. I'll also post the code in the chat later on in case you missed it now. Post the link in the chat in case you missed it. In case you missed it now. I'm a bit excited, sorry. And also, we would like to announce that we will be putting together a special issue on network theory and its implications for psychological therapies in cognitive therapy and research, Stefan Hoffmann's journal. And you can find details on the call for submission using this QR code. And I will also post that in the chat later. Now, most of us mental health have been brought up with the common cause theory of mental disorder, which briefly posits that symptoms are due to a disorder, which in turn has a cause, and we have to address the cause so the disorder will improve and the symptoms will disappear. That's how we have been conditioned to think. Now, the network theory of mental disorder takes a slightly different view. It takes a view that symptoms aren't passive indicators of a disease, but rather active ingredients, active components, and their interaction is what maintains the problem. And it has often been likened to a flock of birds. If you imagine a flock of birds and wonder, how does this flocking behavior come about? The answer isn't that there's one bird that's guiding the others. The answer isn't that there's one invisible force that's guiding all these birds. The answer is the flock is an emergent property of the interaction of the birds among each other. Now, hopla. Now, I believe that the common cause model of mental disorder definitely also has its value. And it basically works like this. You define a group of patients and examine a certain set of characteristics in these patients, a psychological function deficit, and then develop a treatment program that targets this deficit to treat the disorder. And that has been quite successful. Using this method, we have developed a broad range of treatments and can now treat disorders that were once thought to be untreatable. That's a big advance. And yet, even with these very effective treatment methods, we're not helping all patients. Not all of our patients respond. And those who don't respond often have comorbid problems. They don't have one disorder, they have several disorders. And especially for these patients, it might be really, really helpful to kind of shift the focus to a different way of looking at mental disorders. And that's the network theory of mental disorders. And briefly, this, if you take an example to try and understand this theory, it goes like this. Imagine I had early morning awakening this morning. Now, if I have early morning awakening, I may or may not go on to ruminate. And if I go on to ruminate, I'm probably tired. And if I'm tired because I haven't fallen back asleep, I may or may not get up in the morning. But even if I don't get up, I may or may not miss important appointments because I might get up later. Even if I miss important appointments, I may or may not feel guilty about it because I might just say to myself, I'm having a bad day, things happen, da da da. But if I do feel guilty about it, I'm more likely to feel depressed and so on and so forth. So a disorder from this perspective comes about because of the interaction of these elements in a network. Now, this view is one important basis for process-based therapy developed by Stefan Hoffmann and Steve Hayes. And the idea that is very familiar to us in the ACT community is we are not taking a protocol for syndrome approach here, but rather an individualized approach, individual case conceptualization for every single patient. And network theory can help us here because you can draw networks that help you understand how these elements in a network interact, where they are feedback loops that can contribute to a given problem. And one very simple example comes from our department of psychosomatics, where we had a patient who had restrictive eating behavior in the upper left quadrant of the matrix. And we try to understand what brings this restrictive eating behavior about. And we found that for her, it was the thought, I'm not good enough. And eventually we understood that this thought, I'm not good enough, doesn't only trigger the restrictive eating behavior, but also her social withdrawal and her depression. And later we also found that if this thought, I'm not good enough, is particularly strong, she also exhibited self-injurious behavior. So this thought and these symptoms were closely connected in a network. And the goal of therapy from this perspective is to perturb this network, probably by trying to help her understand that the thought, I'm not good enough, is also reflective of a value she has to interact with other people. And we try and help her interact with other people in the presence of the thought, I'm not good enough, to kind of have this element in the network connect with other elements in the network that are more conducive to her health. Now, if you want to do this kind of work, you need certain statistical basics. And I'll just briefly introduce them. First of all, collection of data. You can estimate networks based on cross-sectional data or on longitudinal data. But cross-sectional data will only give you average associations between elements in a network, whereas longitudinal data can also give you an individual structure and dynamics of a network. And if you draw a network, you can look at different features of the network. You can look at density versus sparsity, how many of the potential associations in the network between these elements in the network actually exist. You can look at centrality, which of the elements in the network is central in this network. And then you can also look at the strength of the associations between the elements in a network. And after you've done that, you also have to test for stability of these networks.